Yeah, hello everybody. This is our, a symposium about the new TCP technology for treating critical limb ischemic patient. It's sponsored by MedAlliance. We want to say thank you for that. I'm here with a distinctive panel with Daniel van den Heuvel on my left side, and then George Adams, and Bella Husen is also somewhere in the audience.
She's going to be
online.
virtual.
Online. Oh, so sorry. I didn't get that. So I guess we can right now start with Bella with the overview about the novel solution SLR technology and the clinical update.
Hi, can you hear me okay?
We can hear you, yes.
Fab. Sorry, I can't be there in person. Unfortunately, I can't travel. So I'll be talking to you about the novel solution balloon and the clinical update. My name is Bella Housen. I'm one of the IR consultants in the UK. These are my disclosures. So essentially, the sirolimus balloon that we're going to be talking about had gone through a rigorous phase of different designs. And the main goals were essentially to try and create a balloon that will ensure adequate drug uptake and for the drug to retain, to allow a release mechanism robust enough to ensure vessel patency, but also at the same time ensure that the drug does the action and does not embolize or wash off, whether during the delivery process or within tissues that we don't want it to embolize to. So how was this achieved? Essentially, the solution, a sirolimus balloon, was created using a biodegradable polymer. This is a micro reservoir. And the whole point of this is to ensure that the drug is released in a controlled and sustained manner. In this instance, it can last in the tissue with an effect up to 90 days. The properties are quite complex in the sense this is the reason why you haven't seen it for such a long time. But the properties will ensure that the drug will reach the target areas, lower dose drug concentration than anticipated with other drug-coated balloon technologies that we have at the moment. What we do know and what we're familiar with is paclitaxel. Now, they are technically from similar family groups, but they are different. So in essence, the main essential point differences between paclitaxel and sirolimus for me is that sirolimus offers an anti-inflammatory property. I think if you go into a microvascular level, you'll see that a lot of what we do is traumatic and it does cause a cascade of inflammatory reactions. So any drug that we can use that helps patency, but also allows an anti-inflammatory response is a good thing. One of the other differences is there's a low tissue absorption with a short tissue retention when you compare this to paclitaxel. Whether you believe in the hypothesis and the mortality associated with paclitaxel or not, I think in general, when dealing with drugs and the therapy that we use for PAD or CLI, we should try and ensure low toxicity or tissue retention as much as possible. So in terms of the comparison between the sirolimus and your bog standard home balloons, here you can see that with the MedAlliance solution balloon, the arterial drug concentration is very high in the first hour, and then there's a gradual reduction over 60 days, but still retained in comparison to the other balloons. The same as well for drug dose per balloon size. This is another algorithm diagram to show you how it relates in comparison to the Lutonix and impact. Again, you can see that a lot of the drug is being lost during the procedure with our standard paclitaxel balloons, whereas with sirolimus, it's retained and therefore transferred to the actual tissue that we want. And I think one of the main things is understanding on a microscopic level, the solution balloon offers a homogeneous coating and crystalline coating compared to other balloons. This is probably a better diagram just to show you that I know that a lot of us initially when we were dealing with paclitaxel balloons, you may have got the powder on your gloves, or if for any reason you weren't able to cover it properly, you'll see bits of powder around your procedure, whereas this does not exist with the solution balloon. You don't get that. The loading of the balloon is fairly simple and easy, straightforward. I think also at this point, from a clinical perspective, the balloons come in an 018 system between 2 to 7 millimeter diameter and various lengths from 2 to 15 centimeters. So there's the reduced flow phenomena and washout that we have experienced with paclitaxel. I know some colleagues do not find it concerning. A lot of the time they say that essentially it resolves. But I think the more you use and the longer the balloons you use, the chances of that happening with paclitaxel are greater. We don't tend to see that with sirolimus. Certainly in my practice, I've never seen anything of any embolization or any slow phenomena in any of the procedures, no matter how many balloons or length I'm using. And these are interesting studies just to reiterate the findings that we've seen on a clinical practice. So in terms of clinical data and trials, there's a lot going on at the moment. Greater than 1,900 patients have been enrolled worldwide, as you can see, various trials from RCT to also real life data and in-house collection. Now, my colleagues are going to go thoroughly through this, but I'm just going to briefly focus on the early experience from the solution where 50 patients were enrolled. And this is where the promising data came in that gave confidence to pursue and advance what we can understand and learn by the use of sirolimus and CLI in PAD patients. What's interesting is the latest data from Japan from Professor Lida and team. This is a 12-month follow-up data, and it's 134 subjects, and I would like to congratulate the team. It's an amazing achievement to actually follow up that many patients. What's interesting here is that the majority of the data represents real-life cases. Majority of the patients are diabetic. There is a good representation of task C, not so much D, but task C lesions. Even though the study was open to Rutherford 3-4 cases, the majority have been between the second and third Rutherford classification. Classification was extreme, and grade 3 and 4 make up about 40% of the cases. So with the 12-month primary patency, we've seen excellent results, 87%. And then when we look at freedom from TLR, we see that at 12 months, almost 97%. Now, how does this compare to other RCT trials? Interestingly, you'll see that this is the largest data in comparison to any of the other studies, and there's more popliteal involvement than any of the other studies, 48%, staggering number compared to any of the other trials. And despite all of this, the patency is 87.9, so almost 88%, which almost correlates similar to the IMPACT study, though higher number of patients being involved. So in conclusion, these are, again, promising results, and they kind of correlate with the studies and the figures we've been getting. The study was challenging, like I said, complex patients, popliteal involvement, long lesion lengths, and despite that, significant promising data. I want to share with you in-house clinical cases. Now, I don't use sirolimus in isolation. I tend to use it in conjunction with lithotripsy. And these are the kind of day-to-day cases that I obtain. They're mostly heavy, calcified, occlusive lesions, distal SFA, popliteal, and crural vessels. In this case, without obviously going and divulging, it's very important to size. So I oversize with the lithotripsy and then follow with the sirolimus balloon. And the results have been excellent. Both balloon qualities are fantastic, which ensures that there's no dissections. And touch wood, so far in my experience over the last 2 years, probably more than 30 cases, I've not experienced dissection with either treatments, and I tend to combine the two together, like I mentioned. So again, just to show you that there's excellent results, no dissection, and I'm not seeing this slow phenomena or embolization process in distal vessels. So in conclusion, this is a very interesting drug technology. I think we are behind in the PAD peripheral world compared to cardiology. This is something they've used for a very long time. If, like me, you've used the Zion's Prime stents, which is a sirolimus-coated stent, you'll know that we have been using it for a long time. Results have been good. It's just a case of getting used to that concept, understanding why it's taken such a long time for it to come because of the design idea. It's not easily applied as paclitaxel was. However, the retention and the outcomes are very promising, and I do look forward to further data. Essentially, what we do have to bear in mind is that not all DCBs are equally created, and that goes literally from the basic of the plastic used to the coating, to the drug, to the amount, to the microreservoirs applied. And here we have a very excellent design with the solution balloon, something that I'm using in my clinical practice. I'm happy to continue using. There's further data coming out, and my colleagues will do obviously a better job than me in speaking about the data. So please do join any of these talks if you want to understand a bit more about the recent data and current data. Thank you.
Thank you, Bella. We have decided to have the discussion at the end. Is this okay for you? And we move on with our talks, and we would really appreciate if you stay connected with us. So the next talk is given by Daniel van den Heuvel, the rationale and design of the solution BTK trial. Please, Daniel.
Well, thank you, Marianne, for the introduction. Yes, the rationale and design of the solution for BTK trial. I think Bella did a great job of explaining why we want to do this. These are my disclosures. I have none regarding this talk. So if you look at BTK arteries, they are much more challenging than the above-the-knee arteries. And we've seen that probably as a result with the negative trials of the paclitaxel-coated balloons, with positive results above the knee and below the knee, some negative results. There were various studies investigating paclitaxel-coated balloons, and essentially the endpoints were not met. So why is this so different? When we look at other trials using drug-coated technology in below the knee, we have some very interesting trials using limus as a drug. And these were all essentially stent trials, of course, because we did not have the technique to have limus coated on the balloon. We know the Achilles trial that compared sirolimus-eluting stents with POBA in favor of the stent. Also the Destiny trial in favor of the everolimus-eluting stent. And we have the positive UCAN trial demonstrating superiority of the sirolimus-eluting stents. So there must be something in this limus. The solution for the solution balloon has already been explained by Bella, is a special balloon, and it took some time to develop this. It was difficult to get the drug on the balloon, but we managed with a biodegradable polymer intermixed with sirolimus drug. By doing this, we have this controlled and sustained drug release mechanism, which has a continued effect over 90 days. And this is essentially the same what we have with the drug-coated stents. There's a specific technology, the cell adherent technology, that protects the balloon from wash-off while advancing through the lesion. And thereby we also have a lower drug dose on the balloon itself. As referred to, several trials with a lot of patients, over 1,900 patients already included, mainly in SFA. And like paclitaxel, it makes sense to first try this technique in SFA and then go for the more challenging lesions below the knee. The solution for BTK study obviously is for below the knee. And two studies, let's say, first studies to demonstrate effectivity were the Prestige and the Pristine studies. Small studies, but very promising results. Both were prospective studies looking at freedom for device or procedure-related mortality as a safety endpoint. Then the efficacy endpoints of both studies with freedom from target lesion revascularization at 6 months and 12 months. These are the results. Primary patency of both studies, good, promising, 80% at 6 months and 80% at 12 months. Freedom from TLR, very high rates, amputation-free survival, very good results, and also wound healing shows very promising results. Somewhat lower wound healing in the Pristine trial, but that was because more Rutherford 6 patients were included in this trial. So the solution for BTK is an IDE FDA trial. The objectives are to demonstrate superior efficacy and equivalent safety of the solution balloon as compared to POBA. The design was a prospective multi-center single-blinded trial. Over 350 patients will be included in Europe and the USA. 40 sites will be including patients, and follow-up will be up to 5 years. Primary endpoints: efficacy, defined as freedom from target lesion occlusion, above the ankle amputation, and clinically driven TLR. And then the safety endpoint is freedom from major adverse limb events and POD. Follow-up, very, I think, standard, 1, 3, 6, and 12 months, and then yearly thereafter. Currently, the study is enrolling patients, and our PIs are Aaron Armstrong and Marianne Brodman. It's a core lab adjudicated trial, both for angio, duplex, as well as for wound healing. These are the sites in Europe, just to show you, give you an idea, and here are the sites in the US. Key inclusion criteria: patients with Rutherford 4 to 6 can be enrolled. Patients need to have lesions distal to the tibial plateau, but above the tibial talar joint. Reference diameter of the vessel between 2 and 4 millimeters. Patent runoff, and there must be a successful pre-dilatation before a patient can be included. And this pre-dilatation was defined as less than 30% residual stenosis, no embolization, and no grade C or higher dissections as demonstrated by angiography. I think standard key exclusion criteria. I think the most important maybe to point out here today is the prior DCB or drug-eluting stent or better metal stents are not allowed to be enrolled in the study. This is the treatment flow chart. If in case there is inflow disease, there must be a successful inflow treatment. And if the operator is thinks that drug-eluting technology is appropriate here, then because it's an IDE FDA trial, it must be the solution 018 platform that needs to be used. If the inflow lesion treatment was not successful, then the patients are considered as screen failures and are follow-up when treated, if treated with the 018 solution balloon. After successful treatment, there needs to be an adequate and successful BTK lesion preparation. If this is successful, then, only then, the randomization process can be done. And then it's one-to-one randomization between the solution SLR balloon or standard POBA. So my take-home message of today is I really need and I'm interested in having the solution for BTK trial running. The sirolimus has proven to be effective for a longer period of time than paclitaxel has. It's anti-restenotic as well as an anti-inflammatory drug that makes sense to use in this challenging vessels. Smooth coating, different than some of the paclitaxel balloons, enabling smooth delivery. And I think we have some promising results from 2 small studies showing clinical benefit. And the randomized trial, the solution for BTK, which is currently enrolling patients in Europe and the US, will compare the solution for BTK to POBA in a randomized fashion. Thank you very much.
So, yes, thank you very much, Daniel, for the overview about the solution of BTK trial design and the rationale behind. So we have now 2 cases, one from Europe, which I'm going to present, and the other one from the US cohort, which is George going to present. So just let's start with the European one. So we are also able to take part in this really very interesting and fascinating trial. So I'm just going to present the case from the solution below the knee study. This is a 75-year-old male patient, history of diabetes, myocardial infarction, hypertension, stroke, smoking, hyperlipidemia, and has a wound on the left foot on the first toe. It is a de novo wound. And this is the angiogram about the inflow, showing that there is not really substantial disease. And you see then that the outflow, which is a single vessel outflow, because he has really a very, very, very tiny peroneal artery. So we were concentrating on the anterior tibial artery with this lesion. So this is the wound situation of the patient. We were then doing a pre-dilatation with a Bobo balloon and with the Bobo balloon, and then we did we were showing the angiogram after the Boba pre-dilatation and post-dilatation, and this was just, you know, the end, because this patient was included in the Boba arm and was not included into the DCP arm. So 1 month post-intervention, the wound is improving, the vessel is patent, and we did a duplex ultrasound examination with no sign of restenosis. So thank you, and now I'm handing over to George for his case. I'm not quite sure if this was the whole case. I'm not quite sure.
Great. If I could get my slides, please. Marianne, thanks. It's a pleasure to be here. Great. All right, so this is another case. I'm very excited to present this. So this is a 67-year-old female, typical comorbidities, diabetes, hypertension, high cholesterol, with a failing to heal right great toe wound. So as you can see here, there were some lesions in this leg. The info looked pretty good. And the P3 segment of the popliteal is this top red, this arrow shows you. There's probably about a 60% stenosis. At the level of the P3 segment into the anterior tibial and the TP trunk, we have significant disease. Again, a great toe wound, angiosome concept, anterior tibial is what I'm trying to make sure we improve flow to. As you can see here to the right of the slide, the anterior tibial supplies the plantar loop that backfills the PT distribution, which is occluded. We performed an intravascular ultrasound, and I think this is important. There's been a lot of discussion about intravascular ultrasound. It tells you the characteristics of the plaque. The reference vessel, about 2.5 millimeters. You've got this heterogeneous calcific plaque as we're coming back through the lesion. And as you see, as we get to the tightest points, it gets snug against the catheter, almost occlusive. And then it pulls back into the popliteal. As you can see here, it's widening. And then as we get into that stenosis, we should see that here in a second. You see this heterogeneous plaque, again, clamping down on the catheter. So, actually, let me go back one. Here we go. So just to give you still frames, the reference vessel diameter, about 2.65 millimeters. Heterogeneous calcific plaque, as we described. And then I tried to give you a reference to the far right of the popliteal segment. So there's no guessing involved. In terms of prepping the vessel, again, a lot of discussion around lithotripsy. Bella said that she uses a lot of lithotripsy. I used orbital atherectomy because this was heterogeneous calcific plaque. As you can see, this is a 2.0 classic Diamondback orbital atherectomy, really doing our best to prep the vessel. To do two things. Number one, to score the plaque, so when you go in with balloon angioplasty afterward, you get a nice lumen with reducing your risk of dissection and perforation. And the second thing is if you can adequately prep the intima and medial calcium, hopefully you won't get that recoil. As you can see here to the far right, after orbital atherectomy, we had a really nice result. And then we performed balloon angioplasty. I used a 5 by 40 NC balloon, as you can see here, and then I used a 3.0 non-compliant balloon, which is not shown, to prep it, and then followed it with a 3 by 120 solution drug-eluting balloon. Again, not a drug-coated balloon, a drug-eluting balloon, because it's slowly eluting that sirolimus over time. The other thing is after you deliver the solution drug-eluting balloon, you don't want to use any other therapies afterward, because remember, these microreservoirs, as Bella discussed earlier, are attached to the vessel and you don't want to knock them off. So this should be your final treatment. And as you can see angiographically, here to the far left, you've got a nice inline flow, TIMI 3 flow as we describe in the coronaries, nice flow down the anterior tibial and perineal. And as you can see to the far right, this anterior tibial, you get nice flow to the loop, backfilling the posterior tibial distribution, and it adequately supplied all the toes. I will tell you that after this intervention, within 6 weeks, the right great toe wound had healed. We then brought the patient back for a 6-month look. And I think this is probably one of the most important things with the study, is this angiographic assessment afterward at 6 months. And I think everyone can appreciate, not only in the popliteal segment, but into that anterior tibial segment and the TP trunk segment, we've got nice inline flow. I performed intravascular ultrasound just to see what our reference vessel size was through that tightest portion, and it was about 2.4 to 2.5 millimeters, maybe a 0.1 to 0.2 millimeter recoil. And then as you can see here to the far right, again, nice inline flow to the plantar loop, backfilling the posterior tibial, and adequate flow to the digitals. Thank you very much for your attention.
So thank you very much for all these great contributions, and we have now enough time for discussion. So hopefully Bella is still there. Can you hear us?
Yes.
Okay, great. We can hear you as well. So the first question from my side, what will be the difference with regard to this technology, especially in the below-the-knee space?
I think we're in a very exciting period of time. I think it's going to be a promising technology. We're probably going to see more patency and less dissection with this technology. I don't believe it will be a solo act. I believe it will be in a combination of other treatments, because obviously you still have to cross the lesion, you still need to access, you still need to prep the vessel. But I think it will be the definitive ceiling to a lot of our work. So fingers crossed for the rest of the information that's going to come out with the studies, but so far so promising.
Because I was really, surprised that you are using shockwave lithoplasty, George is using atherectomy, CSI in these calcified lesions, and we see these good results. So what's your explanation? Is it the vessel prep, or is it the combination, as Bella has pointed out?
Yeah, so I strongly believe it's a combination, right? Currently to date, we've really not had anything below the knee that has helped us to prevent the restenosis. I think all of us have learned that adequate prep, whether it be with lithotripsy, whether it be with atherectomy, whether it be with a non-compliant balloon, is important to affect not only patency or keeping the vessel open, but that recoil. What this does is it adds an additional therapy to prevent that inflammatory response, that restenosis, that neointimal proliferation that we have not been able to address in the past. So I think this is important technology, and it's very promising.
Daniel?
Yeah, what this session shows is that we have, let's say, if I may, the European way of doing things and the US way of doing things. We have a lot of vessel prep atherectomy in the US. In Europe, I think it's less, Marianne.
Yes,
and
yes.
Probably has different reasons. But if you look at the histology of the occlusions we have to treat BTK, to me, as a European, it makes more and more sense to go the way George is doing it. Because it's difficult to imagine sometimes that if we have this chronic thrombus and we dilate, that thereby we have this good drug penetration and good end results. I think it's, as George referred to, you need to have a good clinical acute result. So less dissections, less recoil, and then for the longer term results, we need to have a sustained lumen by reducing intimal hyperplasia. And for this, I think this combination of therapies is probably the best way to do it. The way I do it now in my clinic, because we don't have the availability of all the unlimited availability of the atherectomy devices, that I still try to get the optimal result by progressive dilatation of the below the knee artery. So if the reference diameter is 3, I start with a 2, then 2.5, and then end up with a drug-eluting balloon. But I think there are probably many ways to Rome.
Yeah, I guess we all came to the agreement that an aggressive under or an optimal vessel prep is aggressive is a hard word, but optimal vessel prep is necessary to have really good results. And Bella has also shown that above the knee with shockwave, with lithoplasty, she is also able to achieve this great results. So I think sirolimus is for sure, and we have data. Bella has shown the data sets. You have mentioned that. So I think we already have a really good, solid data set about how sirolimus is working in different vessel beds. And for me, especially below the knee in critical lymphocythemia, I think this no distal embolization issue is very important. What do the others think?
For sure, Marianne. It's the case you showed. It looks like a very, let's say, easy case.
Yeah.
But if you treat this easy case in a difficult way, and the meaning only doing POBA, you can create let's say, a cascade of maybe progressive stenosis, then occlusion, which will have effect on the distal perfusion of the foot. So I think these, especially these very, let's say, easy-looking lesions, they probably are the most interesting to me to treat with this extra treatment, like with vessel prep and a sustainable result with the drug-eluting balloon. Because with this short lesion, you know that you're dealing with a short lesion, you know you will not have long dissections, and the results will be optimal. With the paclitaxel, I have, I think, 2 important observations. One is that I did see no flow phenomenon with the paclitaxel. I do not have the experience yet with the solution SLR, so I cannot comment on this. But also I've seen, and I don't know if you have the same impression, I have seen degeneration of the vessel wall after paclitaxel in BTK. Arteries that start to look like veins. And for me that's also a point to take home, because if it's true that paclitaxel, which is a cytotoxic agent, causes vessel degeneration with eventually sometimes occlusion, thrombotic occlusion of the artery, then you have a very difficult clinical situation. And hopefully with the limus, which is a cytostatic drug, this will not happen.
Yeah, I would agree wholeheartedly. I mean, just imagine we have a therapy that we can actually use below the knee, which has been lacking. And, all of us treat critical limb ischemia, a lot of it, and those options just have not been available historically with many failed trials. But imagine if you take a therapy that not only we can use below the knee, but it has an anti-inflammatory response. Remember, inflammation, when you look at pathologies that throughout the entire body, is all revolved around inflammation. So if you can take a therapy that is anti-inflammatory and, as you said, cytostatic rather than cytotoxic, rather than killing the cell, and reduces your risk of throwing distal debris, it sounds very intuitive that this would be a therapy that would be very beneficial to the patient and hopefully improve outcomes. So I'm very excited about it, no question.
And I think another outstanding fact of this solution below the knee study is that we include Rutherford 6 patients as well. So I think this is some kind of guidance to real world, because we never have included Rutherford 6 in other trials, and this is an FDA trial. So I think this is really a very, very important issue. And I also would like to stress the fact that we have a 6-month objective evaluation of the target lesion, and I think this is also outstanding. What do you think about this, angiographic follow-up at 6 months, how necessary it is to help us with the, outcome?
Yeah, I agree. So trial design historically too has been a major issue. And I think it's more than just looking at whether the vessel's open or closed. I think the benefits of these biologic therapies are that it prevents restenosis. And it's not necessarily, you look at it on a spectrum, right? It's not just a yes or no answer, open or closed. It's how closed is it? Because flow is based on the diameter of the vessel, right? And as the diameter decreases, you get less flow. So I think it's very important from an angiographic standpoint, that 6-month follow-up, to see how well the vessel has reacted to the treatment that has been given.
It also removes operator dependence. So in the past, if you do a Doppler follow-up, that's operator dependent, whereas if you're doing the angio follow-up, you can't really debate that. It's solid evidence to the patency and the diameter.
And I think that's very important, especially in the below-the-knee space, that we have this objective follow-up parameter. Yeah, so thank you very much. I guess we had a very, very lively discussion about this new technology. I would not say new, but evaluated technology in randomized controlled studies. Sirolimus, the solution technology in above and below the knee as well. And we are looking forward to creating this data and hopefully present you updated data next year at LINC. I think it's really very, very interesting, and it might change or will change the field of especially below the knee interventions. Thank you very much, and also thank you to my panelists and to Bella joining us remotely. Thank you very much appreciated.